Hey, good morning. This is the July Edina Fire Training recap. There was two big things that we talked about this month. The first was talking about holds, and then we also talked about a pediatric drowning call. So to summarize, with the holds, we had a training sergeant from Edina Police come in, and we talked about their perspective on things. They're taking some of that back to the police side, so these discussions will continue. And again, to reiterate, there's not going to be a solution for all of these. It's a complex problem. It's not easily solved. So when you think about the layers of the issues in culture and people with more chemical dependency issues, more mental health issues, all of this is on the rise. We have job security because of it. These things aren't going to get better. There's not going to be less calls, and we will always be dealing with this on the back end. So both us and police have policy, procedure, and protocol that we have to follow to treat suspects on their side, patients on our side. But the suspect or the patient always gets a vote, and they will do what's in their best interest to meet their immediate needs. Most of these folks don't have a long-term plan for whatever reason because of the situation they're in. Again, that's based on what's happened to them, based on personal decisions. It's usually a combination of those two things that put people in bad situations where we have to get called, especially when it relates to these things where maybe they need to be on a hold. So without assigning blame to any of that, we just need to understand that it exists, and it's not something that we're going to solve. But the patient always has a vote. They can do whatever they want to meet their immediate needs, whether that means saying that they have chest pain to get out of the cold, and then in the morning when they feel better and can get to McDonald's and get something to eat and stay warm, then they're fine. And then they're going to have chest pain again that night when it gets cold, right? Like, we can't control any of that. So it's just up to us to do our best to do what's best for the patient. So a couple points about that. When you're on scene and things get a little heated about the holds or get contentious, more discussions is better than less. So between the officers on scene and the firefighters on scene, if you need to bump it to sergeant and captain, that's fine. Do that. Have more discussions about that. Figure out, why are we doing this? Where are we going? Why are we going there? Is this a legit hold or not? Like, all of those, more discussion is better in this case. So, and always keep this in mind, do what's best for the patient. That's the bottom line. The inconvenience to either police or fire is not our biggest concern. Operationally, there are considerations. Running out of the city with somebody on a hold, I get that, but always keep in mind, do what's best for the patient. Related to that, when it comes to delays, this came up, and it sounds like it's not very common, but it sticks in everybody's head because it makes them, it's a very uncomfortable call. But if there's going to be a big delay and it's going to change patient care, that's when the medics need to get down the road. They need to tell the cops, hey, we got to go. So this patient's getting more agitated. We're either going to have to fight or restrain or sedate a patient. So that's changing their care. So if the patient would stay calm enough to just get to the ER, if you had the hold in hand and could go, right, that's the ideal. But if it's escalating and you don't have the hold, that's when you tell the cops, like, hey, you're going to have to meet us there. We need to get going, because we don't want to do more to the patient than we would have to do if we could just simply get down the road and manage it that way. So if things are going to escalate or change, that's when you need to make the decision. We're going. Sorry, we'll get the paperwork in a bit. But that would change patient care, and that's not doing what's best for the patient, right? We don't need more interventions for the patient, so keep that in mind. And lastly, there's a question came up about if somebody wants to jump out of the ambulance and they're not on a hold, or even if they are on a hold, and now maybe they weren't on a hold, and now you're rolling down to Hennepin, and now they decide they want to get out, right? I'm not asking anyone to go into harm's way. So if they want to get out, you stop the ambulance, open the doors, and get out. If you can talk them down, and again, every situation is going to be different, but if you can just talk them down and convince them to stay, put the seatbelt back on, sure, that's great. But if it escalates in a hurry, or even if you're not able to talk them down, it just keeps escalating, stop the ambulance and let them out. I'm never going to ask you to go into harm's way. So on the PEDS drowning call, this case was managed very well. There was lots of challenges with it. Everybody is on high alert. When it's a PEDS case, it's more stressful for everybody. There's bystanders. It's unfortunately a bad outcome, but the case was managed very well. So, and I agree with the decision to stay and play. The crew picked 20 minutes. I don't have an exact number for that, but I think that made sense. And then also, I would say, with kids like in this situation, or kids in critical situations like this, you should eventually go to the ER. 85-year-old guy with cardiac arrest that you work for 20 minutes, 30 minutes, you probably say, okay, we're done. Kids, I would say, get to the ER. There's social work, chaplains, the appearance of doing everything possible, and not that there's going to be a whole lot's going to change. Even in this kid in the ER, they got Ross, but it wasn't any big different intervention than what had been happening on scene. But I still think it was the right decision to go to the ER, especially with bystanders and everybody's got their phone out videoing things. It's a really tough call to stay on scene and just leave a dead kid. So I would say don't do that. So get things cooking as much as you can, and then at some point make a decision to get down the road. So, and kids get worked longer, again, because everybody is more emotionally charged. The kid will get worked longer, even in the ER. Even probably, I've done this myself. I've seen it happen to other providers taking care of kids. Everybody cares so much that kids often get worked longer, even though things are not looking good. So, eventually get down the road. A couple other quick things. Discussion of ECMO came up. Minneapolis kids can do ECMO on kids for hypoxia, and this kid had hypoxia because of drowning, but they can't do it fast. I checked with some other medical directors, and it's a possibility for like kids who are in the ICU who are getting worse, they can get them on ECMO, but it doesn't happen in the same way that we do ECMO for adults with cardiac arrest. So no need to run down the road for that, because that's not going to happen. Somebody asked about, is a ventilator, getting a kid on the ventilator so you can have PEEP on the ventilator to keep those alveoli open. Because remember, we talked about with drowning, it's not like the lungs fill up with fluid like a Bugs Bunny cartoon. It's more just the surfactant gets wrecked from a little bit of water, and then the alveoli don't stay open. So that's a much bigger piece of it. So you do have a PEEP valve on the BVMs. We played with that a little bit at training, and that's something that we need to keep training on. So you can use that to try to get PEEP and make sure you have a good seal. So yes, you don't actually get PEEP, but you have that pop-off valve to use to give a little more pressure to try to keep the alveoli open. You just need to be careful with that when you trigger that valve. And so last thing, we talk about hand heavy. And I would say look things up. When it comes to peds, I don't memorize anything when it comes to peds. When I have a peds case that comes in the ER, I have the book out and I'm looking up what size blade do I need, what size tube do I need. I don't try to remember, like, it's the size of the kid's little finger, or it's 4 divided by 3 plus 3, their age. And like, there's an opportunity cost to memorizing obscure facts, and all the stuff that you use every day that you need to be really good at. There's not space in your brain for all of that. You can't possibly remember all the obscure facts. So look it up, have a resource, either hard copy, electronic copy, you have something. There will be some resource that you can look up with these cases. So we talked about volume versus concentration when we're talking about dosing this. And I think it worked out really well on the call, the way the medics were communicating about how much volume to give of a medication. Keep in mind the volume that works if the concentrations are always the same. And most of the time, that's probably going to be fine. The thing to keep in mind, though, is if the concentration of the medication changes, and now you're talking about volume, obviously you're giving a different dose of the medication. So I would say there's benefit to both of those, but just understand what we're talking about. If you're calling out a dose to somebody who's giving a med, yeah, you're certainly hearing the volume that you need to draw up. That makes way more sense, and that's most of hand heavy. But again, just keep in mind, if concentrations change, if we have a medication that we can't get and we have to change the concentration, that can become an issue. So just be aware of it. So that's it. See you next month.